Case number 21. A 40-year-old female had an incidental pelvico-abdominal mass. MRI showed a large midline and right paramedian pelvico-abdominal multilocular cystic mass lesion. It showed thin internal septations with no evidence of papillary projection, soft tissue component, or pathological enhancement. Cystectomy was done. Cut section showed a mostly solid mass with scattered cystic spaces. Microscopic examination. These two micrographs demonstrate multilocular cystic spaces lined by simple epithelium, that is, bland Müllerian type epithelia. Hybrid morphology, serous and mucinous, of the cystic lining. Prominent fibrous stroma. Lack of architectural complexity or cellular stratifications. These images demonstrate a cystic wall lined by simple epithelium consisting of attenuated serous type cells without cilia, endocervical type columnar mucinous cells, an admixture of cytologically bland Müllerian type epithelia in varying proportion. The lining shows no evidence of architectural complexity, cellular stratifications, or atypia. These two micrographs demonstrate cyst wall with a prominent fibrous stromal component, simple epithelium consisting of cuboidal to low columnar serous type ciliated cells, occasional stratification. These micrographs demonstrate cystic wall lined by cuboidal to low columnar serous ciliated tubal cells, epithelial papillary tufting, no evidence of architectural complexity, cellular stratifications, or atypia. Okay, what is the diagnosis? It is ovarian seromucinous cystadenofibroma. Ovarian seromucinous tumors include benign seromucinous tumors such as cystadenoma, cystadenofibroma, and adenofibroma. Seromucinous borderline tumor. Seromucinous carcinoma. It is non-existent. Okay, let's talk about ovarian benign seromucinous tumors. General background. Seromucinous cystadenoma, cystadenofibroma, and adenofibroma are rare benign ovarian epithelial tumors exhibiting admixture of two or more Müllerian type epithelia, mucinous, serous, and endometrioid, each accounting for at least 10% of the epithelium. They occur over a wide age range, but are most common in the reproductive age group. They are frequently associated with endometriosis. Clinical features discovered incidentally during workup of other gynecological diseases. May present with an abdominal mass, abdominal pain, or vaginal bleeding. Bilateral in 40% of cases. Mean size is 9 cm, generally smaller than intestinal type neoplasms. Prognosis and therapy. Seromucinous cystadenomas, adenofibromas, and cystadenofibromas are benign. They are almost always confined to the ovary. Complete excision, cystectomy, or oophorectomy is curative. To minimize surgical morbidity, laparoscopic removal is often performed. Seromucinous borderline tumor. It accounts for 5% to 15% of these tumors and is strongly associated with endometriosis in up to 50%. It is composed of papillae exhibiting hierarchical branching with edematous or fibrous cores. It is lined by an admixture of Müllerian type epithelium, including cuboidal to columnar mucin secreting epithelium, ciliated epithelium, and eosinophilic pink cells that frequently exfoliate from the tips of the papillae. Nuclear atypia is mild to moderate. Mitotic figures may be present, but are usually infrequent. Prognosis and treatment of seromucinous borderline tumor. Conservative treatment with cystectomy or admixectomy is indicated in reproductive age women. It requires follow-up as recurrences may occur. Chemotherapy is not indicated even for patients with high-stage disease. No deaths have been attributed to this tumor type. It is important to note that seromucinous carcinoma does not exist, as these tumors can be reclassified as endometrioid, majority, serous, or mucinous based on morphology, immunophenotype, and molecular features. These are the references. Thank you.